Hello everyone, and thank you for attending today's webinar. Before we begin, we want to cover a few housekeeping items. At the bottom of your audience console are multiple application widgets that you can use. You can expand each widget by clicking on the maximize icon on the top right of the widget, or by dragging the bottom right corner of the widget panel. This webinar is being recorded, and the recording will be available 1 day after the webcast, both at the same audience link used for today's webcast. If you have any questions for presenters during the webcast, you can click on the Q&A widget at the bottom and submit your question. We will try to answer as many questions as possible during today's event, but if a fuller answer is required or we run out of time, your question will be answered later via email. We do capture all questions. If you have any technical difficulties, please click on the Help widget. It has a question mark icon and covers common technical issues. You can also use the Q&A widget for technical issues. Now, I would like to pass it over to Susan Arday. Susan, you now have the floor.
Thank you. I'd like to welcome everyone to today's webinar on electronic clinical quality measures titled Eligible Clinician eCQM Diabetes Measures. Let me advance your slide for you here. This is the third in our eCQM series of webinars for eligible clinicians. My name is Susan Arday. I am the CMS Contracting Officer's Representative, or CORE, for the CMS contract tasked with maintaining the electronic clinical quality measures, or eCQMs, that are used in the CMS Merit-Based Incentive Payment System, abbreviated MIPS. I will be presenting today along with Dan Roman from the National Committee for Quality Assurance, NCQA. And today we're going to present three measures. The first will be Quality ID number 1, CMS 122, diabetes, hemoglobin A1c, poor control, greater than 9%. The second measure is going to be Quality ID 117, also known as CMS 131, diabetes, eye exam. And the third measure will be Quality ID 119, CMS 134, diabetes, medical attention for nephropathy. All three of these measures are in the top 10 reported eCQMs for MIPS, and as such, there are many questions that come in. And today our speaker will review the specifications and address the most common questions that are received. At the end of today's session, you will be able to be familiar with the top reported diabetes eCQMs. You'll better understand the most frequently asked questions and answers for each of these eCQMs, and how to follow ongoing information about these measures in JIRA through the ONC project tracking system. You'll also learn about changes to these eCQMs for program year 2019 MIPS reporting, including new CQL updates. I'd like to note that the staff and speakers have no financial arrangements or affiliations with corporate organizations that either provide educational grants to this program or may be referenced in this particular activity. And at this time, I will hand the presentation over to Dan Roman from NCQA to discuss CMS 122, the diabetes measure, hemoglobin A1c, poor control, greater than 9%. Dan, you have the floor.
Thank you, Susan. This is Dan Roman. I'm a Senior Research Associate at NCQA, and I work on our measures focused on cardiovascular and diabetes care. As Susan said, I'll be providing an overview of these measures and answering your questions today. The first measure is the hemoglobin A1c poor control greater than 9 measure. This measure is based on guidance from the American Diabetes Association that recommends lower goals goals of less than 8 for most individuals with diabetes and even less than 7 for some. We also know that HbA1c test results can vary by 0.5% in what they're really telling us. So with all of this in mind, a result of greater than 9% is problematic and really not representative of what's considered good care, hence the measure name poor control. So diving into the measure components, the measure description is the percentage of patients 18 to 75 years of age with diabetes who had a hemoglobin A1c greater than 9 during the measurement period. The denominator is going to be all patients age 18 to 75 with a diagnosis of diabetes, and a visit during the measurement period. That latter piece about a visit during the measurement year is intended to make sure that the patient is actually currently seeing the provider who is reporting the measure. We exclude patients who are in hospice during the measurement period, and that's because the evidence supporting this measure is intended for the more general healthy population of individuals with diabetes and not those with a more complex, frail condition. And we'll see the same exclusion in the next two measures for that same reason. The numerator is focused on patients from the denominator whose most recent HbA1c result was greater than 9. There are no denominator exceptions for this measure, and the improvement notation is lower score indicates better quality. That's because, as I mentioned earlier, this measure is looking for an indication of poor care, an HbA1c result greater than 9, so the score should be low. Moving on to some frequently asked questions, what qualifies for reporting the numerator? So obviously, an HbA1c result greater than 9 is what we're looking for. But since we're also looking for indications of poor care, we also count situations where we see a test ordered without any result present in the record or findable, searchable by whoever's reporting the measure, or cases where there has been no test during the year. And that's because we would expect to see at least one test with a result during the year for any individual with diabetes. If we don't see that at all, this is an indication that potentially no one is monitoring that particular individual's diabetes care. Another frequently asked question that we get about this measure is what specific lab tests count for the measure? And so that might seem obvious, but the language used in the medical records and in the code descriptions for HbA1c tests can vary somewhat. So we see things like we have listed on the screen here, like A1c, HbA1c, glycohemoglobin, and glycosylated hemoglobin. The answer is that all of these count, and in general, the best rule to follow is that this is an e-measure. Stick to what's provided in the value set, and you're not going to use any test result that is inappropriate. Speaking of value sets, we did have some changes from last reporting year to this reporting year. We removed some codes that we decided were inappropriate for identifying people with type 1 and type 2 diabetes from the diabetes value set. We also added the office visit value set and home healthcare services value sets. And that's because we decided that the face-to-face interaction value set was obsolete. That's the value set we used to identify encounters for this measure. And we decided that it really wasn't representing how care is being delivered, so we removed it and replaced it with our office visit and home healthcare services value sets. As far as terminologies used in this measure, we use ICD-10, CPT, SNOMED, and LOINC. There are also a couple direct reference codes, which are essentially just attributes in the measure logic that reference a single code. For this measure, we have direct reference codes for discharges to healthcare facilities for hospice care and discharges to home for hospice care. So those would be used in identifying patients for the exclusion in this measure. On this slide, let's see what slide we're on. Slide 13. We just have a screenshot of the CQL logic for the measure. So this is covering the initial patient population, the denominator, the exclusions, and the numerator. So with that, I would turn it over for questions and answers about the diabetes hemoglobin A1c poor control measure.
Thank you, Dan. This is Susan Arday. At this time, I'd like to turn it over to Anita to see if there are questions that have come in through the chat. Anita? Oops, sorry about that. You have 4.
Thanks, Susan. And Dan, you're very popular today. The first question is, have CPT codes 92012 and 92014, which are both ophthalmology codes, been removed from Quality ID measure number 1 in error?
That is a good question, and without digging into the value set a little bit more, and I might be able to do this on the call, I can't answer it just off the top of my head. but I can take a look at it. Would you mind saying the codes one more time?
92012 and 92014. And again, those are ophthalmology codes.
So for this particular, I will say this, for this particular measure, those codes wouldn't count because we wouldn't expect that HbA1c is being measured or monitored at an ophthalmologist, with an ophthalmologist. So I'm wondering if maybe that question is geared towards the eye exam measure, which we'll be discussing next. But for this measure, those codes, you wouldn't expect that ophthalmologist is monitoring HbA1c, so I'm not sure why they would have been included to begin with.
Thanks, Dan. The next question is, I haven't been able to find a national benchmark for foot exams for a provider practice. Are you aware of one? Thank you.
So for foot exams, which that is not a measure that is no longer that is a measure that actually was part of the eCQM program previously. I believe it was dropped for this reporting year. It's no longer part of the set that clinicians will report for 2019. The national benchmark, there is no national benchmark as far as I'm aware. We do have a HEDIS measure that's used at the physician level. It's used in NCQA's provider program. We have a diabetes recognition program here at NCQA where we use it, and it's at the physician level. That's the only place where I know that that measure is being used and where we might be able to find a benchmark, but it is not part of this set of e-measures any longer.
Okay, thanks, Dan. The next question is asking for clarification on the denominator age. Is 18 to 75 during any time in the reporting period or 18 to 75 during the visit that happens within that reporting period?
So I believe the way the e-measure is going to work is it's looking for anybody who's 18 to 75 during the measurement year. The way the logic works out, it's looking for the overlap of anybody who has diabetes who meets the criteria of 18 to 75 during the measurement year and has a visit during the measurement year. So all of those things need to happen and overlap with the measurement year for them to count for this measure and for any of these measures.
Great. Thanks, Dan. The next one is there consideration for denominator exclusions for residents of long-term care facilities?
So for right now, that is not part of the measure, as we just saw. We do actually consider, we are looking at that for other measures outside of this program, and that might be something that gets worked into the e-measure in the future. So it is something that is being considered. So I guess to answer the question briefly, yes, there is some consideration for adding that to the measure as something we would exclude. However, just to be clear, that is not part of the measure currently. It may be part of a spec in the future, though.
Okay, our next question is, what if the patient has a 9.1 in June, but a 7.0 in September? Will they still be considered poor control?
That is a great question because I probably did not say it clearly when I was reading through the specification earlier. The measure is specifically looking for the most recent result. So in that case, that person would not count for the measure because their most recent result was a 7, which would be a good result. Again, this measure is looking for kind of bad care where we're seeing a patient whose results are too high and kind of out of the range of what is recommended by the clinical guidelines. And since for this measure we kind of have to decide to look for one result, not look at all of them across the board throughout the year. We're focusing on one result. We look at the most recent, so that ends up being the last one of the year, if there are multiple results. And so in this case, that person would not qualify for the numerator, which is a good thing because, again, a lower score is better.
Thanks for that clarification, Dan. The next question is, can the value be reported by the patient, or does the provider have to obtain the A1c?
For this particular measure, we have not started allowing patient-reported results. These should be coming from a provider ordering lab results, and the lab results coming back to the provider, and they should have them in their record. There's still some concerns about patient-reported results used in measures in general, about the validity of them and whether or not the recall is correct and where it's coming from. And so there's a variety of factors that we're still kind of looking over and considering for whether or not to include patient-reported results for any measure. For this one in particular, we have not started using patient-reported results to count for this numerator.
Okay, the next one is, how do you account for new onset diabetic whose A1c may very likely be above 9?
So it all would depend, I suppose that would depend on when they are, when the results come in during the year. So there very likely might be some patients whose results, they only have one result and it's at the end of the year, and it's not going to look good because they haven't gotten under control. We would think that overall that's a small percentage of the population that's being included and likely is going to be kind of a wash across all providers reporting the measure. So it would be very difficult for us to work in that caveat into the measure of who to exclude. And you'd also not want to necessarily exclude that because you want to shine a light on that situation because that person, you know, their first HbA1c is going to come in. They're not under control, so they are not getting. They have not received the care yet that they're probably going to get. But you need to show that. We need to know that. And so yes, you know, they may get under control within the next several months. That would be outside of the measurement year. But for any individual who is new to being newly diagnosed with diabetes and has a higher result throughout the rest of the year, HbA1c tests should, in theory, be done almost every 3 months because that's about what they're going to show you as far as their blood sugar and being under control is about 3 months. So, you know, at least one a year, if not more. And so again, that would really only count or really only be that would only be a problem for someone newly diagnosed right at the end of the year where they might only have that first test where you're getting a sense of what their HbA1c values are. And again, you'd want to know that. So it's not something you want to hide or exclude from the measure.
Well, Dan, we need to move on to your next presentation. We do still have a number of questions, so we do want to just let participants know we will get answers out to all the questions that we received. But right now, Susan, I'm turning it back over to you.
Thank you, Anita. Next, Dan's going to present on CMS 131, the eye exam. Dan, you have the floor.
Thanks, Susan. So as just heard, we're now going to talk about our diabetes eye exam measure. This measure is also based on guidance from the American Diabetes Association, and it recommends annual eye exams for individuals with diabetes to look for retinopathy. That guidance also indicates, though, that if no retinopathy is found during one particular year, an exam every other year may be appropriate. And so we'll see how this plays out in the numerator once we get ahead a couple slides. So our measure description here is the percentage of patients 18 to 75 with diabetes who had a retinal or dilated eye exam by an eye care professional during the measurement period, or a negative retinal exam. In other words, no evidence of retinopathy was found in the 12 months prior to the measurement period. We have the same denominator as the previous measure, which is patients 18 to 75 with diabetes, and we have the same exclusion for patients who are in hospice care during the measurement period. Our numerator for this measure, we are looking for patients who received an eye exam, an eye screening for diabetic retinal disease. We look specifically for exams performed by an eye care professional during the measurement year that indicate the retina was examined, or we look for those same type of exams during the previous year performed by an eye care professional where there was a negative finding or no evidence of retinopathy. There are no denominator exceptions, and this is a measure where higher is better. The higher the score, the better the performance on the measure, and that's because here we're looking for good quality care as opposed to what we were talking about in the previous measure. As far as some frequently asked questions go, what counts? Again, what counts for the measure when we're reporting this numerator? So as I said, we're looking for exams during the measurement year that indicate the retina was examined, or we want to see that there was an exam in the previous year where there was no evidence of retinopathy found. So an exam during the measurement year is going to count, and we're not concerned about the result during that measurement year because we just want to see that there's an annual exam. If there was no annual exam, we want to see in the previous year that there was an exam, but that no evidence of retinopathy was found. So that means that the exam happened, the patient's eyes looked healthy, and the next year they get a pass for having an exam. But then again, we would want to see that there was an exam that next year if there wasn't one during the measurement year. Another question we often get is what counts as evidence of an exam? So first of all, we want to see that an exam was performed by an eye care professional. So that includes an optometrist or an ophthalmologist. We do allow charts or images that were taken outside of the eye care professional's office, as long as there's some indication that an eye care professional reviewed the image and provided an interpretation. And that, again, is based on the current guidance that we have from the American Diabetes Association that requires that an eye care professional is the one doing the exam or interpreting the images or the charts that are come out of the exam. Another piece of this, of what counts as an exam, is ties to the value set that we use. It includes a wide variety of codes, and they are all proxies for exams that took place where the retina had to have been examined. So if you look in the code set, there is just a large group of codes that some don't necessarily intuitively say or say they don't straightforwardly say there was an eye exam, but they are things that are they're procedures that are performed that somebody had to be looking at the retina in order to have done what is qualifying in what is in the code description. So it's kind of a proxy for an eye exam being performed again, where we know that the retina had to have been examined. And then another question is about patient-reported results. So this is something we receive on the e-measure, a question we receive on the e-measure, and on the HEDIS parent version of this measure. And as I was saying earlier, we're considering the possibility of counting patient-reported results across all of our measures, but we take it measure by measure and what we think would be reasonable to include or not to include. And so for this particular measure, the answer is yes. We do allow patient-reported results, but there are some criteria that must be met. So first, there must be evidence that the exam was performed during the measurement year or the year previously, that the exam was performed by an eye care professional, an ophthalmologist or an optometrist, the date of the exam, and the results. So the patient would have to be able to provide all that information, and it has to get into the chart in some way, some structured field that is reportable by an e-measure. But if it came from the patient and it met all those criteria, we would allow it for this measure. As far as the value sets and the changes that may have taken place from last reporting year to this year, we have that same change for the diabetes value set where we removed some codes that we felt were inappropriate for identifying individuals with diabetes, type 1 and type 2. We added those same value sets, the office visit and the home healthcare services value sets, to replace the face-to-face interaction value set, which we felt was obsolete and no longer representing the care that's being delivered currently for individuals with diabetes. The measure terminologies are the same as the previous measure. We use ICD-10, CPT codes, SNOMED codes, and LOIN codes. And as far as direct reference codes, we have the discharge to healthcare facility for hospice care, discharge to home for hospice care, and we have negative finding direct reference code. And that negative finding is specific to that piece of the numerator where we're looking at exams that took place in the previous year, and no indication of retinopathy was found. And so that's how that particular attribute, that direct reference code of negative finding, is used in this measure. And just to wrap things up on the eye exam, before we go to questions, we have a screen capture of some of the logic here, where we cover the initial patient population, the denominator, the exclusions, and the numerator. So with that, I will now turn it back over to Susan for questions.
Thank you, Dan. At this time, I'd like to turn it over to Anita to see if there are questions that have come in through the chat. Anita, you have the floor.
Thanks, Susan. And once again, Dan, we have a lot of questions for you. Okay, the first is, do you look for providers with a taxonomy indicating eye care professional for compliance for this measure? Many community health centers have retinal photography machines that do not require an eye care professional to operate.
Yeah, that is a great question, and it's one that gets to one of the biggest challenges with this measure for it being used as an electronic clinical quality measure in the program. We do not currently. One of the challenges is still that we're looking for this. This is meant to be a measure that can be used by any provider who's providing the general care for a patient with diabetes. And so it gets difficult because you want to see that the data from an ophthalmologist and optometrist got into the provider who's reporting the measure into their record. And so currently we don't require that for this e-measure, that whoever's reporting the measure, that they're an ophthalmologist or an optometrist. We are, however, I will say, we are looking into ways for improving this, since we know that there's a bit of a flow of data issue with this measure for some providers and for some vendors of EHRs for capturing it correctly, for making sure that you're getting the results from an optometrist or an ophthalmologist into the general care, the general practitioner who's reporting the measure, into their health record. So currently, no, but we are working on that for future versions of the measure.
Thanks,
and I will just say
a
clarification about that. The codes that we do have in the value set, though, are specific to they should be codes that are only being used by ophthalmologists and optometrists. And we include in there also, for any time there's a chart or remote image taken, the description, I believe, includes stipulation that it has been reviewed or interpreted by an eye care professional. But again, that gets to some of the data challenges we have with this particular measure, where there's multiple actors involved and the data is being reported by one provider, and we want to make sure it's all there. We are working on ways to improve this measure for future versions of this specification.
Thanks, Dan. The next question, are blind patients excluded?
So currently, blind patients are not excluded from the measure. This goes back to some coding, some of the lack of efficacy of the codes that existed previously, where we were not able to determine from the codes whether or not somebody was legally blind but probably still should be getting eye exams versus 100% blind, and there really is no reason to be looking for retinopathy anymore. That's another thing that for this particular specification, this version of the measure, we do not include, but that is absolutely on our list of things to try to work into the measure for a future specification. Just a reminder about the timing for when these specifications are updated. It's almost a 2-year time period for when we make an update to the spec and for when it gets published for use. So there is some lag time there where things we're working on or things we have for future specs, things we're talking about right now, it takes some time to get them into the specs. But it is the blindness is absolutely something that we're trying to work in using the current version, current coding into the measure.
Thanks, Dan. The next question is, what would you consider to be patient-reported evidence that the eye exam was done?
So, yep, and great question, and that's something we wrestle with, like I said, with a lot of our measures. For this measure, we're looking for the patient to be able to have provided to the provider, and it gets into the medical record, because I think that's a key component. It's not, it has to be there, and the provider says, "This, I will accept this, and this is going to be in the record." And obviously, because it has to be part of the e-measure that's getting reported. So all this information has to get into the record. As I said, it has to be that they have evidence that the exam took place, that they know the date, the result, and that it was performed by an eye care provider, so an optometrist or an ophthalmologist. We know that we know that data isn't always shared between providers, and so we know there's lots of times where a patient might come in and say, "Yes, I had an eye exam, here's where it happened, here's when it happened," and they know the results. So we think that at least requiring that the patient having to be able to provide certain bits of information gives us a little more reassurance that, yes, this is a valid piece of information, and this should be acceptable for use in the measure. And especially since if the provider deems it appropriate and they put it into the medical record and it's usable in structured fields, that an e-measure is going to be able to pull that information, then we think it's usable.
Okay, thanks. The next question is, would you quickly repeat if it has to be an optometrist or is an ophthalmologist required?
So yeah, the eye exam should be performed by an optometrist or an ophthalmologist. Those are the only two types of eye care professionals that we count for the measure. So they either perform the exam or they provide an interpretation of results, an interpretation of images or reports that are generated remotely, because again, we know that that is another thing that is occurring currently in practice, where there are facilities that provide imaging or photography that can be taken, that can be done remotely, and as long as it's interpreted by an optometrist or an ophthalmologist, it counts for the measure.
Would providers such as a physician assistant or nurse practitioner specializing in eye disease also be an acceptable provider?
That's a great question and something that we should put on our list for consideration for the future. The current specification does not allow for that, and it doesn't allow for it in any version of this measure. So even in the HEDIS version, the parent version of this measure, we only count ophthalmologists and optometrists in this current specification. But again, that should be something we have that on our list of things to consider for the future.
Okay, I think this may be the last question that we have time for. If the result is negative and the date of the prior exam is 2018, will that qualify and count for this reporting period?
Do you mind reading that beginning part just one more time, because I want to make sure I got that right?
If the result is negative and the date of the prior exam was 2018, will that qualify as counting for this reporting period?
Yes, because so this reporting period, 2019, you're looking at 2018 data, and what that is telling us is that there was an exam in 2018 with a negative result. So we wouldn't require that the result even is there for 2018, since it's going to count for the results you report for 2019. It means that an exam took place. For the future version, for the future of this measure, what that'll then say is that the next year, that patient, if there is no eye exam, that's okay, because in 2018 there was a negative result. So for 2019, when the patient is receiving care, they can get a pass on getting the eye exam according to the measure. Now, of course, in clinical care and the provider, in reality, the provider, that's what they deem necessary for how often the patient gets the eye exam. That is completely up to them and up to their clinical judgment. For the purposes of the measure, a negative result in 2018 would mean that for 2019, they don't necessarily need the eye exam. Just to be clear, though, you keep in mind, in 2019, you're reporting results, reporting data from 2018. So the case you're talking about, that means that there was an eye exam in 2018, and they are a numerator hit for this measure, which is good.
Okay, and Dan, that takes us, we are out of time to continue answering questions right now, so I'm going to turn it back to Susan.
Thank you, Anita. Next, Dan's going to present on CMS 134, medical attention for nephropathy. Dan, you have the floor.
Thank you. So, as Susan said, we're now talking about our diabetes medical attention for nephropathy measure. This measure is also based on guidance from the American Diabetes Association that recommends that individuals with diabetes should have their kidney health assessed at least once a year. There are some variations in how that guidance is discussed and whether or not, depending on when they're diagnosed, and some kidney values, how often they should be assessed, and what exactly should be done. This measure in particular is taking a very high-level look at whether or not patients with diabetes are having their kidney health addressed. And so we look for a variety of things during the measurement year. And again, we'll get into that as we dive into the measure components. So our measure description is the percentage of patients 18 to 75 with diabetes who had a nephropathy screening test or evidence of nephropathy during the measurement period. We have the same denominator where we're looking for patients 18 to 75 with diabetes who had a visit during the measurement year. And for the exclusions, it's that same exclusion for patients who are receiving hospice care during the measurement year. Our numerator, as I said, it's patients with a screening for nephropathy or evidence of nephropathy during the measurement year. There are no denominator exceptions, and similar to the last measure, the improvement notation is higher score indicates better quality, because again, we're looking for good care where there's attention paid to the patient's kidney care at least once during the year. So when you see it, that's a numerator hit, and that means your score goes up, which is what we want to see for this measure. The main question we get about this, and it breaks down, it can break into a lot of different questions, is what counts for numerator, for qualifying for the numerator. As I was saying, we're looking for evidence of, I actually think that some words got cut off this slide. We're looking for evidence of a nephropathy screening or that the patient was diagnosed with nephropathy. So the way we look for that is screening for kidney disease, so a variety of tests that are looking for protein in the urine. And again, there's a value set that covers all of that. And then we're also looking for treatment for kidney disease, and so that might come in the form of a visit with a nephrologist. But again, there's a variety of things we look for in the measure that cover that. I think one other thing that we include in this measure is treatment for kidney disease. So there are some medications like ACE and ARBs. Again, I apologize. I think something got cut off from this slide. As part of the treatment for kidney disease, we might see medications like ACE or ARBs which are used to treat kidney disease. So that's another thing we look for in this measure as part of the numerator. As far as changes to the value sets, we have that same change for the diabetes value set where we removed some codes we thought were inappropriate. We also added and removed codes for the glomerular nephritis and nephrotic syndrome value set, the hypertensive chronic kidney disease value set, and the proteinuria value set, where we added some codes that we decided were appropriate to be included in the value set. And then we also removed some codes from the urine protein test value set. As far as terminologies go, we use ICD-10, CPT, SNOMED, and LOINC. And then we have those two direct reference codes that we use for the hospice exclusion, which are discharge to healthcare facility for hospice care and discharge to home for hospice care. And then we'll finish up with this before questions with just a screenshot of the CQL where we cover the initial patient population, the denominator exclusions, and the numerator. And here you can actually see in this numerator where we look for an active medications of ACE or ARBs, we look for a diagnosis of nephropathy, or we're looking for some sort of nephropathy screening. And now I'll turn it back over for questions.
Thank you, Dan. This is Susan Arday again. And at this time, I would like to thank our presenter, Dan Roman, and I'd like to turn this over to Anita to see if there are any final questions that have come in through the chat. Anita, you have the floor.
Hi, Dan. Yes, we have some more questions. The first one is, if there is a diagnosis, is the diagnosis itself sufficient as a numerator definition, or would appropriate medication or other treatment need to be shown also? If so, what are those medications, treatments, and are there resources?
So as far as so if there's a diagnosis, I'm taking that as there is a diagnosis of nephropathy. That is going to count for the measure. So that would indicate to us that somebody has paid attention to this patient's kidney health. Again, there's lots of other things. This measure does not incorporate everything and all things that would be done for somebody who might have kidney disease as a result of their diabetes. This is a very high-level look at, is somebody paying attention to the patient's kidneys? And so seeing a diagnosis during the measurement year of nephropathy means that somebody has looked at it and somebody has found that there is a problem. So we do count that. As far as the medications that are included in this measure, the only things that are counted are ACE or ARB medications. There are a host of other things that would potentially be considered and prescribed or recommended for this patient. This measure in particular is only looking for ACE or ARBs, and that on its own would qualify for numerator, would qualify for the numerator for this measure. That we're not looking for a diagnosis of nephropathy and then medications as well. This is an either-or type of thing because, again, we know that there's a variety of things that might show up in the medical record that indicate somebody is paying attention to the patient's kidneys. So the only medications we look for are active medications of ACE or ARBs.
Thanks, Dan. The next question is, does the protein test need to have a numeric value? We frequently see a result of positive instead of a numeric result.
We actually, for this measure, are not looking for the results. So that might sound funny, but we are not concerned with the results specifically. This measure doesn't go any further than looking for that there was some tests looking for kidney disease. So as long as there was a test ordered, that is numerator compliance for this measure, or qualifying for the numerator. We don't care. I mean, we care about the result, but the measure is not concerned with whether or not the result was positive or negative or what the number was. We're just looking for that there was a test ordered or test performed that falls within the value set that we've provided that looks for a nephropathy screening.
Great. The next question is, would a diagnosis of CKD or chronic kidney disease count in the numerator?
Yes, those are part of the diagnoses that we include for a nephropathy value set. It's a whole list of kidney disease ranging from mild to severe kidney disease that we count for this measure. So any evidence that nephropathy or kidney disease has been diagnosed is going to count. So those two, yes, those would count.
Great. The next is, would a clinic-performed urinalysis qualify as screening for kidney disease?
Providing that the lab test performed is represented as one of the LOINC codes we provide in the value set for the nephropathy screening value set, then yes, we do not provide we don't have any requirements about that specific, like the location of where it was performed. We are only looking at certain codes that we are counting for this value set. So providing that the test you just mentioned lines up with a code, can be billed or can be coded to fit with the LOINC code that we provide, a LOINC code we provide in our value set, then yes.
Great. The next question is, what evidence of nephropathy should be included in the chart? So I think here they want to know, is it certain diagnosis codes, or is there something else that needs to be in there?
Yeah, so for evidence of nephropathy, it's certain diagnosis codes. It's going to be the codes that fall into the nephropathy diagnoses value set, and so that is things like a diagnosis of chronic kidney disease or ESRD. It's a decent list, but it is going to be diagnosis codes, and again, they should fit within the value set that's provided, since this is an e-measure.
Dan, the next one is there a list of tests that qualify for this measure? If so, where do we find that list?
Yep, the list of tests are going to be in the nephropathy screening value set. So the tests that qualify are going to line up, are going to match to the codes that we provided in the value set for nephropathy screening. That is the easiest thing to look at because it's already there for you. It's all right in the value set. And you want to align with that, and that way there's no question. If it's not in that value set, then it's not going to count for this current version of the measure. Now, I will just say, we are always looking for new codes that might be appropriate because we know the terminologies are updated quite often. So we try to add those whenever we're able to, but we do have to stick kind of within the within the time frames for when we update these measures. So there may be codes that are representing some sort of lab test that is looking for nephropathy that is not part of our value set, but for the purposes of qualifying for this measure, you have to use the code sets that are provided.
And thanks, Dan. The next question is, does a prescription of ePoetin qualify a patient for this measure? So that would indicate that the patient has kidney disease, if they're on that. Would that qualify a patient for this measure?
Yeah, I believe that right now that is not on our list of medications that we include for the measure, for counting for the numerator. Again, in reality, that might be totally appropriate. However, what is in the measure specification that currently would not count, since it is not in the value sets of things that count for the numerator. But that's a great question that is something we can put on our list for updates to the spec to make sure that we include, if it's appropriate, for a future version.
Great. The next question is, what if the provider did not prescribe an ACE-ARB but screened for nephropathy as the ACE-ARB may not be clinically appropriate?
Yep, and that makes total sense, that situation, because ACE and ARBs aren't necessarily appropriate for everyone with kidney disease. This measure, again, is not looking to see that there's both. It's an either-or type situation. So we would look for ACE or ARBs. We would look for nephropathy diagnoses, so anything that fits within the list that we've provided, such as kidney disease, ESRD, different stages of chronic kidney disease, or that there's a nephropathy screening test ordered. So in this case, if they ordered the test during the measurement year, that would count for the measure. There's no you order the test and prescribe something. That's not how the numerator works. We're just looking for one of those three things: the ACE or ARB medications, a diagnosis, or a nephropathy screening.
Great. The next question is, if the result or exam documentation is located in the EHR that allows for viewing external results, would this suffice for the exam portion of the evidence for patient reported? So in other words, they're able to look at the results that others had in the EHR.
I believe the answer is yes. I feel like more detail might be required to answer that question. if the results are viewable by the EHR and it can be reported for this program, then there's no reason why they wouldn't be allowed. There's some mention in that question of patient-reported. Patient-reported results aren't generally allowed for this measure, so we don't specifically have anything that kicks out patient-reported results in the measure logic. So potentially this measure, if it's implemented in an EHR where it picks up any results like that, they would end up counting. But the guidance generally around this measure is that patient-reported results we have not started to count patient-reported results for our nephropathy measure. So again, like I said, they probably would need a little more detail about the question about the specific setup that they're talking about, the commenter is talking about, to answer, the best that I can. But if it's something that is picked up within the EHR and it's mapped appropriately so that the e-measure can report it automatically, then it probably is going to end up counting. If they have a field that says patient-reported results, that shouldn't be included for this measure, for how the measure is implemented in the EHR, though, because currently we don't allow patient-reported results for the medical attention for nephropathy measure.
Okay, great. This is a question that came in a few times. Does the test need to be completed or just ordered?
That is a good question. We would like to say that, I would like to say that there has to be a completion of some sort, but I believe the way the logic works is that we are just looking for a test to be performed. So I want to say that might be one that we should follow up on after this meeting, so that I can just make sure that the logic we don't look for a result. But I believe we're just looking for the test to be ordered or performed during the year. So if there's anything about the logic that says it's not completed because there's no result, that's the part I might need to dig into more. So my quick half answer is I believe that as long as it's ordered, it should be fine. But that should be something we should include as kind of a follow-up to this presentation, this discussion, just to be sure that we're answering it completely and correctly. Okay,
the next one of the next questions is, are you looking at pharmacy claims for ACE-ARB? So in other words, are you receiving information on pharmacy claims to make that determination?
That is another good question. I think if there's access to pharmacy claims, they certainly could be used in the EHR. I know that a lot of EHRs do not have that ability to look at pharmacy claims. This measure is looking to see that we're not looking for a dispensing event, though. We are looking for an active prescription and active medication. So it should be the status within the EHR of what is ordered or what's being prescribed. We're not looking specifically for there being a dispensing event, which is often what we need to use pharmacy claims for. So there's some nuances there, but for this measure, we're not requiring that at all. We're looking for what's available in the EHR as far as there's an ACE or an ARB been prescribed or ordered.
Okay. The measure looks at quality of care. Just ordering the test should meet the spirit of the measure, correct?
Can you repeat that one more time?
This measure looks at quality of care. Just ordering the test should meet the spirit of the measure, correct?
Correct. Yes. We are looking for, so the logic itself is looking for the test to be performed, and that, the test itself needs to be performed, and I believe the logic is looking for cases where there is a result. So it's not null. So this gets into e-measure logic. It's looking for tests to be performed and that there is a result. We're not worried about what the result is, but I think it's because, if there's a test ordered but there's no result, that potentially is an issue because you don't really know anything about what's happened. So to meet that kind of higher bar of quality, we're saying we want the test to be ordered and there should be a result. That is in the guts of the logic, of the eMeasure logic, to see that. So we're not worried about the result for the measure, but there should be a result there, and that's how we're considering the test to actually have been performed. I'm glad we got that follow-up question so that I could answer that better.
The next question, and that may be for Susan, we have several questions on where they can find the value sets for this measure, for these measures.
Oh, hi. Yeah, this is Susan Arday. The place to find the value sets for these measures is on the eCQI.health, HEALTHIT.gov website. And that's the Electronic Clinical Quality Improvement Resource Center's website, publicly available.
And so, Susan, at this time, I'm going to turn it back to you so that we can wrap up today's program.
Oh, thank you, Anita. So the Q&As from today's webinar will be made accessible through the Electronic Clinical Quality Improvement Resource Center, the website eCQI.healthit.gov that I just mentioned. And the Resource Center contains information on the diabetes measures as well as the measure specifications for the 2019 reporting program year. And additional questions or issues can be submitted at any time to the eCQM issue tracker in JIRA in the ONC project tracking system, which is oncprojecttracking.healthit.gov. I'd like to quickly go over how you use the ONC project tracker. Let's see here. Whoops. There we go. What you do is you submit questions through JIRA in the ONC project tracking system, and then you follow the instructions outlined on this slide to create an account if you don't already have one, and then follow that up once you get your account with an issue ticket. So I'd like to thank everybody again for joining us today. I'd really like to give big thanks to our presenter, Dan Roman. The next eCQM webinar, which will focus on eCQMs with substantive changes for the 2019 program year, will be held February 27th, 2019 from 1 to 2 p.m. Eastern Time. Registration has been distributed and is also available on the eCQI Resource Center website. Thank you for attending today. Goodbye.